Welcome, everyone. We still have people joining, so we're just going to give it another minute or two. It's nice to see so many faces.
Yeah.
Everyone's excited, Sunny, to learn about all of the data that you collected from our
Yes.
kids.
Yes, of course. That'd be great. Thanks for joining.
Okay. And Amanda, it is already recording, correct?
Correct.
Okay. Welcome, everyone. I'd like to start by thanking all of you for joining the town hall today. As a mom to an SCN2A warrior, I know very well how hard it is to fit anything extra on top of your daily obligations, but we are very happy that you're here today. Dr. Bajaj, aka Sunny, is a neurology resident at UTHealth Houston and an aspiring physician scientist whose work bridges developmental neuroscience with translational applications for rare diseases, just like SCN2A. He was born and raised in Kathmandu, Nepal. He was first introduced to neurodevelopmental disorders at the University of Heidelberg. Hope I got that one out. Um, He moved to the United States in 2023 to pursue residency training with the goal of building a translational research career focused on rare neurodevelopmental disorders. In Houston, he joined the laboratory of Dr. Dennis Lau, collaborating with patients, families, and rare disease foundations to develop quantitative and clinically meaningful approaches to phenotype characterization. Sunny, I am so happy to have you, and I am going to turn it on over to you.
All
Thanks
right.
for joining
Thank you
us.
so much. Thank you, Leah. All right. Thank you, everyone, for joining. Great to see some known faces. I will share my screen so we can get started. All right. Okay. Perfect. Can everyone see my screen?
Looks great.
Perfect. Sounds great. All right. Thank you, everyone, for joining. Today, I'll be talking about motor dysfunction severity and how we understand it in SCN2A related neurodevelopmental disorders. I'll be talking about some of the data that we've collected over the past 2 years in collaboration with everyone, and happy to share the data as well as talk about new endeavors and other things. So look forward to it. So first of all, I want to talk about why do we even study motor function in neurodevelopmental disorders? Oh, and before I continue, I just want to say if anyone has any questions, please feel free to kind of interrupt me and start. I can't really see the screen or who's talking, so if you could just shout in, that's totally fine as well, because this should be interactive. Whenever you see something interesting, please feel free to interrupt. Okay, so why do we study motor function to begin with? As we know, neurodevelopmental disorders are complex disorders of many different impact many different organ systems and functions of the body. And motor dysfunction is something that is actually commonly seen, as we know, in individuals with SRDs and in clinical settings. A lot of patients do describe symptoms that are detected by physicians. And a lot of these papers that are mentioned here with some of the leaders in the field have identified or somehow mentioned cursorily that motor dysfunction is present. Some of these phenotypes, and I've selectively chosen the word suggested because they mention that almost in passing. So there's things like gross and fine motor delay, ataxia, hypotonia. And hypotonia is one that is, of course, emphasized, but a lot of the others are listed but not really emphasized or dug deep into. And that is an issue because motor dysfunction significantly impacts activities of daily living. And we've seen that through caregiver reported information and community surveys, as we see here, as well as qualitative descriptive surveys across the sodium channelopathies. Leah was involved in this as well, across different sodium channelopathies, where we see that gross motor function, fine motor function, as well as ADLs are significantly affected in almost every individual with a neurodevelopmental disorder, and specifically SCN2A and other sodium channelopathies. So without clear descriptions, without standardized assessments, there is a lack essentially of understanding of how severe these disorders are and how we can assess them properly, and what even their role is within the other phenotypes that are present, for example, seizures. Are they related to seizures? Do they come before or after? Are they completely independent? These are things that are not well assessed at all, even though they've been cursorily reported. And what is previous work? What is previous work that has established some of these findings? So there's two major papers. One of them was from Dr. Ingrid Scheffer's group, Van der Veen et al., who selectively chose patients with genetic DEEs, 77 of them, across almost 35 different genes. So very minimal patient numbers across the genes, but they wanted to specifically look at patients with genetic DEEs who were known to have movement disorders. And what they did is they looked at videos from other individuals that was provided by individuals with NDDs and their caregivers, and detected a diverse range of motor dysfunction that is present across these individuals. And similarly, a recent preprint that is from our group with Ludovica leading it looked at almost 1,200 probands across 87 NDDs, and they looked at data that is parent reported from Simon Searchlight and extracted phenotypes. And both of these, basically, the main messages from both of these papers is that motor dysfunction is diverse, is very, very prevalent across these, or is highly frequent across these individuals, and present across most genetic DEs. But both of these papers struggle with the fact that they haven't really quantified motor severity. And that is very difficult because it is something very observational. It is something that requires deep exposure to patients to be able to scale them properly. And we haven't really identified either how the genotype phenotype correlations are, so which specific genetic variants are associated with what kind of phenotypes, and what are the developmental patterns. And that is particularly relevant for us because this is lastly what we want to identify. Are there non-seizure clinical trial measures that we can identify? Because dysfunction and disability in individuals with neurodevelopmental disorders is very hard to quantify so far outside of seizures. And that will be super relevant for the many different trials and the fantastic therapies that are coming through, which we're all very happy about. But we won't really know how we can estimate, is this something that is truly helping us improve the ADLs? Are we only addressing the seizures without addressing some of these other cognitive, behavioral, movement aspects? So understanding motor dysfunction, trying to identify objective, non-caregiver provided phenotypes will be the critical care gap that we have to address. And this is kind of where we come in. Our group was very interested in understanding this, trying to provide new tools for both researchers as well as families to understand what is a non-seizure outcome, how is motor dysfunction defined, and to identify these scalable markers. So before I go into what we did and how we understood it, since this is a town hall, I wanted to take the opportunity to kind of describe a little bit of what motor dysfunction even means and how we can understand it from a caregiver standpoint, because I think it is very important to understand what we're visualizing to be able to accurately also present to the neurologists or other developmental pediatricians we are seeing, because often it may be reported as a seizure, but you may not even understand that some of these aspects may not be a seizure, maybe some kind of movement disorder or motor dysfunction. So I want to take this opportunity to kind of delve into it a little bit. So a little bit of anatomy. I know I don't want to make it too deep, but I just wanted to kind of simplify this and show brain regions that control motor function. And on the left, you'll see like a basic description of the brain, and this is a sagittal section, so we cut it in the middle so we can see the different parts. And what I wanted to focus on is the cerebellum in the back of the brain. And this is a region of the brain that coordinates movement. So it is not really for strength, but it coordinates the movement that is generated by the higher cortical regions that promote movement. And some of the dysfunction that is associated with cerebellar dysfunction is what we call ataxia, which of course everyone has probably heard about. But ataxia essentially just means imbalanced because the core cerebellum, which is one of the major components of it, isn't able to help coordinate between different types of muscle movements. And this includes not only extremities, but also eye movement disorders. So a lot of patients with oculomotor ataxia, so not able to kind of track, are often will be associated with cerebellar dysfunction. There are certain disorders that are more common to have cerebellar dysfunction, but that is something that everyone should kind of be aware of. Where is that ataxia coming from? And then there's the region called the basal ganglia. So the basal ganglia are basically a set of four different nuclei or deep cortical structures. And they also impact the movement that is created in the cortex by controlling the tone, the movement, amplitude, and the rhythm. So essentially, they're a refinery system that kind of coordinates all these movements. And they are very involved in dysfunctions that lead to chorea and dystonia, something that I will explain what it is later. But basically, everything to do with tone is a lot of it is defined by basal ganglia dysfunction. All right. So with that little bit of basic, I will delve into some videos to explain some dysfunctions. So hypotonia is something I think a lot of the caregivers and researchers are very well aware of. And hypotonia essentially means low tone. And it's not really a movement disorder or movement disorder, but it is a significant contributor to the development of future motor dysfunction because essentially what we see in this individual here is that they have no muscle tone to be maintained to maintain their posture. And let me show a video. So this kid, as you can see, is sitting on her back, and as you can see, I'm holding her up with my fingers because her core muscles are so weak, or no, they're not weak actually. So they have no tone that she is unable to sit by herself. And as you can see, every time I leave my finger on one side, she's kind of falling over to that side. And that is a reminiscent of the classic truncal or axial hypotonia that we see in a lot of individuals. And this, as you can think of, is super, super relevant because the video kind of runs out. Because say, for example, this individual, there would be no one holding her, which typically won't be the case. The changes to the structure of the back will be often secondary to this hypotonia. So however they sit for a long time, their muscles kind of contract in that region. So a lot of the scoliosis that we see later on in life is actually due to long-term hypotonia with a reactive kind of positioning that the body takes in. So that's hypotonia. Then I want to talk about ataxia. So we talked about ataxia. It was caused by a lot of the cerebellar dysfunction. And ataxia can represent itself in coordination of eye movement dysfunction, dysfunction of coordination of gait, and also fine motor and gross motor movements. So what you will see here is a little girl who will try to do the classic finger to nose test. And what you will see is ataxia can represent itself. So she has a little bit of cognitive dysfunction as well, so unable to kind of identify that it has to be the right hand. And what you'll see is that she is trying to point to the finger, and you'll see two things. Once she gets closer, you can see that she kind of waves in the air a little bit. The right is okay, it's not too bad. But when you come to the left side, you'll start to see how she's unable to kind of hold, and it kind of sways in the air before it reaches its target. And it's also unable to reach its target perfectly. So that is a classic ataxia, what we're looking for in individuals. And then she's going to try and do what we call rapid movements, rapid alternating movements. And with rapid alternating movements, we're testing again cerebellar dysfunction. How fast can the body coordinate switching between one muscle group to the other? And as you can see, she's unable to really switch and kind of is in the middle and hitting herself rather than being able to coordinately turn or and flip her hands. And these are the kind of things we observe very frequently in clinic because we're doing all these tests. However, we want to be able to quantify them, of course, because without quantification, it is hard to really scale these measures up. So as you can see, the different tests show different things. Which test do you select? How do you select a test that is standardizable across patients? That is kind of the trick here, and that's what I wanted to show with this video. Uh, Now we come to dystonia. So dystonia is persistent contraction of a muscle in a specific way, and it is one of the more severe motor phenotypes or motor dysfunction that we see. And dystonia occurs again, as we mentioned, through circuit dysfunction in the basal ganglia, which coordinate the tone of the muscle rather. And what you will see often is there's multiple types of dystonia. So in this individual, in this video, you can see, so she has neck dystonia, so she how her neck is turned to the left. So that is called torticollis, and it is because of abnormal tone in one side of the muscle or one side of the neck that turns the head. You can see her hands are dystonic, so she's almost like clasping, and you can see how her feet are also kind of bent. And the interesting part here is often what we see in our developmental disorder patients, especially the severe DEs, like this kid, is you see that I'm having to hold her up as well. So it is a combination of hypotonia centrally and dystonia, very severe dystonia distally. And dystonia is something that we should be aware of because often patients who get this dystonic kind of posturing, it is painful and it can often be can often be seen as seizures, although it's actually dystonia that we're seeing. So importantly, differentiating seizures from these kind of abnormal hand movements is very, very important. So if you see this, I think it is very important to videotape and videograph what we're doing here very early on, because some may see this kind of movement as seizures. And of course, some of them are cognitively impaired, unable to speak and tell you what they're feeling and may just be making some sounds. So it is important to videotape so your provider and physician can be able to see it. But you can see how severe this dystonia can be. And apart from the extremity dystonia, we often have oral dystonia and mouth abnormal function. So you can see that this child's mouth is also open all the time, and that is of course also painful, can impair swallowing. So we really need to be careful, understand that these symptoms exist, and bring them to the provider early. And similar to dystonia, something that can often be associated with it, this is also something that is often through the basal ganglia dysfunction, is chorea. And chorea is abnormal dancing-like movements of the hands and feet and extremities. And as you can see, you get the dystonic kind of tone abnormality, but you get these abnormal movements that are going on all the time. And this dysfunction is also very, very hard to treat, is very disabling and difficult to control. So detection of these dance-like movements early can also help us identify ways to initiate medications that are more present in adult individuals who don't really see pediatric patients very much. So seeing the pediatric patient early, identifying that these movement disorders exist, bringing them to a pediatric movement specialist, which may be hard to even find, is how we can kind of try to control these. And finally, I wanted to bring up myoclonus. Myoclonus is involuntary jerks. So this is a little hard to see in this individual, but focus on the left hand over here. You'll see that the left hand is kind of just twitching, as we can colloquially call it. And myoclonus is something that can be seen in many, many different disorders. It can be a seizure type. It can be due to electrolyte imbalances, but it is important to know that myoclonus exists because then we can identify early whether they're part of a seizure complex, which can be treated effectively with medications. Is it due to electrolyte imbalances, or is it just inherent to the movement disorder itself? Because there are a lot of channel diseases that affect the muscles as well, not just, or the nerves that control the muscles and not just the nerves in the brain. So importantly, to know the twitching is very important, that it can be differentiated into myoclonus and a different kind of seizure. And finally, it is important that all of these motor dysfunction and all of these movement disorders are important to assess because all of them can impact walking, which is lastly the major daily life activity that we want to impact and help all our individuals reach. So although this individual, for example, may appear mostly functional, you can see that their gait isn't as stable and they're having to reorient themselves. Their tone in the legs is not perfect as every other person would be. So we can detect even like slight imbalances. For example, how there's a X leg almost appearance here. So it's very important to identify these kind of subtle imbalances that we can maybe even address. And those are the things that are currently not very well addressed in the outcomes. So what was our approach? So our hypothesis was that we can use clinical rating scales, which are observational and sometimes interactive, as well as wearable devices to be able to detect motor phenotypes and motor dysfunction and correlate it with the different kind of genetic variants that are associated with NDDs. And what we did is we prospectively recruited many different individuals across our institution, UTHealth Houston, which has an SCN2A multidisciplinary clinic, as well as many different family foundation conferences. So this was not just SCN2A, we had SCN8A, KCNQ2, CSNK2A1, and CACNA1A. The only inclusion criteria was that we had a variant in a gene that was associated with an NDD, and identified any kind of movement phenotypes that we could using certain scales. And this is, you've already seen a couple of videos, but essentially most of them were done by one neurologist in training, trying to assess these different disorders and record the videos so that we can do post-hoc assessments, do some of the stuff that we're doing today. And now to summarize our rare disease cohort, we performed these assessments in our specialty clinic at UT Houston, as I said, and we had a total of 133 individuals at the end when we stopped recruitment with 11 repeat assessments, and those were all repeat assessments at the SCN2A conference. So we're very thankful for the steady collaboration of all of you because it's been a wonderful experience. And as you can see, the SCN2A cohort was also the largest, so we were at both the 2025 and 2024 conferences. Among these repeat assessments, we had one control and 10, or one control sibling and 10 SCN2A individuals. So very thankful for the steady collaboration and work together. And as you can see, with these number of assessments, we had quite a good amount of individuals that we had phenotyped and wanted to see across different age groups and different ethnicities, which is very nice, what kind of phenotypes we were able to see. So what did we do for the clinical scale-based assessments? So how do we define what we want to see? There's an issue in movement disorder field that we don't have scales that are applicable across a wider age range, but we selected 3 scales that allow us at least the flexibility to be able to assess these 3 major types of motor dysfunctions that we are seeing. So one of them is the modified Ashworth scale, which measures spasticity. Spasticity, I didn't talk about earlier, is actually involve tightening of the muscles that is due to dysfunction of the tract that comes from the higher cortical regions all the way to the muscles. And it is basically very hard to distinguish often from dystonia, particularly in very severe individuals. So that is used the modified Ashford scale for that. Then we use the von der Marsden scale for dystonia and the SARA, which a lot of individuals know for the ataxia. And as you can see, a lot of these individuals are wearing the watch, which I'll be talking about later as well. And using the scales, what we identified is that these scales all have various parameters with specific things. And some of them we talked about earlier, like the nose finger test on the SARA or the fast alternating hand movement, and different body parts that are involved in dystonia. So how do you summarize it so we can actually talk about it in more reasonably? To be able to do that, what we did is we summarized these parameters into subdomains specific to either gross motor function, coordination, speech, and different body parts so we can synthesize it into bite-sized information, understand it better. And this is how we're going to be talking about the results moving forward here. And first, I want to present what we saw across all entities. So this is all individuals on all assessments that we did across all genes or gene variants. And what we see is that motor dysfunction is essentially uh, universal. So what this scoring is, you can see the percentage on the y-axis or percentage of assessments that had any kind of scoring on the gross on any of these metrics, any of these motor phenotypes. And any score of 1 or above was rated as someone having at least involvement of this motor function. And what we can see is that, as I said, it's universal across the board. There are speech deficits, coordination deficits, gross motor deficits. And nicely, we can see that most of the controlled individuals do not have much of these. The ones that we have here are mostly very young individuals that are presenting with some coordination and gross motor deficits. So it may not be true gross motor deficit. They may just be too young. So this is the issue with the scales that we had, that they're not quite optimized for the entire age range. And that is something that the field is struggling with, and we're hoping to address with some maybe newer scales that may be optimized for the NDD cohorts. The only phenotype that we saw wasn't very prominent was spasticity, and this is kind of expected because we don't really see that in individuals with neurodevelopmental defects because they're not really problems of or dysfunction of the corticospinal tracts, but more of these centers that I talked about. But still, control in comparison to controls, it was, of course, more prominent. So that was the first good sign. Okay, we can detect neurodevelopment. We can detect movement motor dysfunction in neurodevelopmental disorders. So moving forward, we looked at how is the severity of these motor phenotypes across entities, and as we can see, it is very diverse. So this is looking at the proportion of the maximal possible score. So basically, if you can get a score of 10 and you got a score of 7 on this scale, you would be around here in the 0.75 range. And then we kind of compared it across all NDDs here. And what you can see is that these dots represent individual assessments, and you can see that there's a very broad range across almost all of these different parameters that we're measuring. So we can see that there's a diverse range of severity across the different genes. That's the different individuals. That's the first thing, but also that we can detect these differences quite nicely. So the scales allow differentiation of individuals based on observation, and there's no real kind of pooling of most of the patients into one specific group because the scales are not applicable to that group. So this was very good for us. So we were able to differentiate even minute differences between individuals. And then on the broader level, what we can see is speech dysfunction is very, very prominent. So even in individuals that may not have very significant gross motor dysfunction, speech dysfunction is quite often very common. So this is something to remember, that there may be a lot of cognitive impairment in individuals that also have speech bias. So maybe our scales are detecting more than just motor dysfunction. They're also detecting cognitive impairment that may be affecting certain components such as speech. And then we see that the diversity of involvement of upper versus lower extremities is also something that we can detect quite separately from each other. So patients that may have axial dystonia may not necessarily, or may not have axial dystonia, may not necessarily also not have involvement of upper extremities. So we can kind of differentiate them. And then, as we discussed, spasticity was kind of low across the board. And then what we did is we put together. So this is an assessment that uses so-called Z-scoring to differentiate how the severity is across the different cohorts that we had for the different genes. And this basically averages the scores across the cohort and then compares the proportion, or compares the different scorings of the different individuals across the different genes. And what we identify here is that, so in here, how you would understand it is red means there is more a higher z-score, which would be associated with higher scores on the scales, whereas blue tiles represent lower z-scores, meaning comparatively lower scores on the scale. And we see that SCN2A individuals, which we'll focus on here, seem to have across the different scales and across the different parameters quite higher z-scores, meaning compared to the other genes here, there seems to be very, very severe involvement in both gross motor and coordination, speech, but also significant dystonia in the upper, lower extremities, and axially. Orbital dystonia was kind of low, but compared to the others, it's still higher z-scores here. What does that mean? I mean, of course, these are very limited numbers because, as you can see, the cohort sizes are quite different. However, what the message here for us was, it is SCN2A can be associated with very, very severe neurodevelopmental disorders. There is severe motor involvement essentially across all domains, and that these scales are capable to detect these and differentiate them from other individuals, but also within the group, which I've not gone into here, but we saw it here, where we could see that the scales are able to detect differences between individuals. So moving forward, identifying which individuals are more severe on the scales and differentiating them from others, doing more variant-based, mechanism-based differentiation will be crucial to identify patients at risk. Now I'll do a little bit of switch. So as I mentioned, we did the
Sunny,
scale
do you
business
mind
of,
if I just interrupt for a second? We did have a question in the chat,
oh,
if you don't
sorry.
mind.
Yes.
Oh, it's
Yes.
fine. So there is a parent in the group, her child is two, and she wants to know if there's a movement disorder that looks similar to chorea, but is only occasional, because her daughter doesn't have it all the time. She says she has odd movements on some days. Her neurologist saw videos and said it may be one of the SCN2A movement disorders like chorea or dystonia, but it doesn't seem to bother her, so don't need to add any meds for it. She was wondering if what you think about that.
Yes. So a lot of the times, so chorea is typically constant. It isn't really episodic. But as you said, what often you have combined with chorea is dystonia. And we can have episodic dystonia, which sometimes is the one that is confused with seizures. Because episodic dystonia is essentially they're normal, 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 and then they'll get like this cramping kind of motion. I mean, that's the way colloquially I would describe it. They just cramp up and then it goes away. And it can look like chorea, but chorea is typically constant dancing-like movements with alternating, fluctuating kind of. And episodic dystonia is hard to treat because episodic dystonia, you can try medications such as baclofen or other tone medications that work over the long time, but they have secondary effects like sedation. So episodic dystonia is often something, as your physician told you, done on an individual basis. Is it frequent enough that you need something that may have the side effect of sedation? But on the other hand, something like Botox is often what we can use as well. So we've seen that Botox can often quite help with episodic dystonia as well, just in that body part. But yes, it is one of those ones that is the most trickiest to treat, but also detect. And then I
Thank
saw
you.
one message.
Oh,
Yeah.
we have one more quick question in the group, and it's on actually about Botox. So many of our kids receive Botox injections for spasticity, and was that accounted for in the research? And could it contribute to low spasticity results? And how, I guess, how is that accounted for in the research that you've conducted?
Yeah, thank you. That is a very important point. We unfortunately did not account for a lot of the medications and the other treatments that individuals are on in this initial study. And that is a confounder that we definitely have to remark. It is kind of across the board, and having that information would be beneficial to report. And when we will be reporting this data, we'll definitely mention that confounder that we don't really have some of this other additional information. And it could definitely affect the spasticity results. But of course, it also affects the dystonia results because dystonia and spasticity are treated equally. So even if individuals are treated with this with Botox for spasticity, it will inherently treat the dystonia as well. So the fact that our scales are able to detect dystonia but not spasticity in patients who may be on Botox tells us a little bit that both are present, but dystonia may or may not be more frequently observed. It's hard to say, but yes, I mean, there's no way around that. I think that it is an issue inherent to our study design for now.
Got it. Thank you so much for explaining that.
Yeah. Okay. Any other questions? If you have, just shout them in. Yeah. I really can't see the screen, so
No worries.
perfect. Yes, thank you. All right, so now to the watch. So this was something we added on as an augment, as an auxiliary, and equally important component. So from the beginning, we've mentioned that it is important to identify objective parameters that are being able that can be used for clinical trials. And while clinical scales are very good and they have basically objective scales and Likert scales you can use, they are, of course, also dependent on the examiner, the experience of the examiner, the level of training, and the specificity of the scales to NDDs. Sometimes they're only optimized for adults is an issue. So can we augment them with something that may be agnostic of the examiner, be scalable even more so because you do not need an examiner at all, will be something that we used the watch for. And the watch we used, as you saw in some of the videos, was the Empatica Embrace Plus. And again, Dennis is here. Thank you so much for Dennis he's the one driving this research and really helping us move forward this kind of objective phenotyping. Is that this watch is able to capture not just accelerometer-based movements, but it also has some sensors. You can see some of these sensors here that project lasers, and they detect the blood volume pulse. So they detect the electrodermal activity, which is essentially how much they're sweating. So a little bit of the autonomic function and the skin temperature. And using these raw data, these parameters, Empatica aims to address some of the other kind of larger measurements we can do, which is heart rate, respiratory rate, the steps and activity counts, and even sleep stages, which are all something that, of course, we are all interested in because, as we mentioned, it's not just motor dysfunction, it is autonomic symptoms, it is a whole host of non-seizure phenotypes that we still have yet to really detect properly. And what did we do in our disease cohort? This is the same cohort as before. So from these 144 assessments, approximately 100 patients have watch data that is recorded for around between 10 to 72 hours. So every conference where we did, or every clinic patient that we had, we would give them the watch, do the assessment that we saw earlier, and give them the watch as well. Either they went home with it and brought them back, or they stayed the whole conference or most of the conference with the watch, and we recorded continuous raw data from these signals. And the first quality parameter was that a lot of the individuals were able to keep on the watch for a long time. So even though some of them may be irritated by it, that was some of our concerns. It didn't really seem to distract them. The app was easy to use, did not distract the caregivers. So essentially, it was very well taken, and we could use the watch effectively in this patient population. And then we derived many different accelerometer-derived features to detect motor dysfunction. So we won't go into details about the accelerometer-derived features itself. So there's features related to acceleration. There's features related to the fluctuation in acceleration. So that helps us give us like information about the variability of movements and how fast or rapid they're changing between directions, and many other things which we can talk about in a different setting. But essentially, these features were able to detect, firstly, just motor dysfunction or motor function to begin with. And there were some minor differences we saw between control and patients, but this was not really the major thing. What we use this is just as a quality control to see, okay, we were able to detect certain things, and there may be a signal between control and patients or individuals with NDDs. And next, we use these features to perform so-called PCA analysis. So PCA analysis essentially is we use many different of these parameters that we created, and using these parameters try to differentiate or find similarities and differences between groups and or between individuals, and then they're projected onto this Cartesian map. And what we can identify is then we can just color the dots based on whether they're patients or controls, and see how they are in how they are in appearance based on the parameters. And what we see is that, as you can see, the patient group separates itself quite nicely from the control group, with some individuals or some individuals with NDDs falling into the control group. So they may be very similar to controls, may not have as much motor dysfunction. And just as a reminder, this is just accelerometer data, so just movement analysis through the three-dimensional kind of features that we can extract from the watch. So that was a good first sign that, hey, we have just 15 parameters that we're extracting, and just based on the movement, there is some signal that is clearly differentiating patients from controls. Now, this is not just SCN2A, this is other individuals as well, but this preliminary data just goes into the gross neurodevelopmental cohort that we have. And then we looked at some of these features and quantitatively analyzed whether these features can discriminate the neurodevelopmental cohort from controls properly. And we did not correct here for sex or age, but based on the 10 most important features when comparing 70 patients with 25 controls, the area under the curve, which is essentially the area under this black line, is 0.83, which is quite good. So something that would be like on a straight line like this would be 0.5, would be something that really does not differentiate false positives from true positives. Whereas here, the higher this the higher this line goes immediately, the better essentially your model is. And this is for a very simple model with only 10 important features. We were quite surprised and quite happy with the fact that we were able to detect differences between controls and NDDs quite well. Now, this is just accelerometer data, so we're hoping that by adding other features into this model, complicating the model further, adding in confounders that are clinically applicable, or even some of the clinical scale data, so the observational data on top of the watch gives you like a combined model that would be able to really provide something objectified, added on with a subjective, semi-objective clinical scale to really differentiate individuals from each other and provide high specificity or sensitivity would be something that is really something we're looking forward to. So we were very encouraged, but we are already very encouraged by this data. And of course, we're still working on this data and improving it further. And finally, we wanted to just give a brief glimpse into how the variable data for some of these other autonomic features look like. So what we're looking at here is one, the heart rate, and second, the heart rate variability for controls in blue and patients in red across individuals under 10 years, over 10 years, and then all ages. And I want to focus on the ones under 10 years of age. And what you see is that at baseline, the heart rate seems to be higher. It's not that different, and we've not done much significance testing because of the cohort size, but also there seems to be a difference in the heart rate variability. So how fast or what the difference is between the highest heart rate that we've ever had and the lowest we measured across the recording time. It was very similar across older individuals, but when you compare all ages, there seems to be more of a difference in the younger ages. Now, why is that the case? Are we detecting something physiological? Is this true for all variants or specific to, for example, the early onset gain of function variants? This is something to look into. But at least what this tells us is that the watch already at a preliminary stage provides valuable data that may be useful in detecting some of these autonomic features that we haven't really delved into much. And for that, there's not really that many scales. So using physiological parameters through measurement tools would be ideal to detect these differences. So we're very encouraged by this as well. It seems to be more in younger individuals, but we'll need more data to confirm these findings, and we'll be looking into this in the next few weeks and months and hoping to refine this further. So to summarize, that was most of the data for today. I didn't want to go make it too complicated, but hope it was something useful and nice. And what are the conclusions? So, as I mentioned throughout the course of the talk, I think both clinical scales and wearable devices are feasible and they're applicable instruments. And that was something that we set out to do primarily as well, is to just make sure that whatever we hypothesized is applicable to the neurodevelopmental cohort with a lot of the other features such as cognitive impairments that are confounders and that may complicate these things that are easier to do in adults. And that is something that is we're very happy about. I do think what we see is diverse and frequent motor dysfunction across not only SCN2A, but other neurodevelopmental disorders, which we thought is true. But what we're able to identify is also differences in the severity, which has so far not been done by any prior studies, because this is a complicated kind of endeavor, as you really have to go to the individuals, identify them early, and measure these tools. And the other part we talked about was that watches and wearable devices may be able to distinguish individuals from controls and could be used as screening tools in addition to clinical scales, and also provide an entry into establishment of autonomic dysfunction measuring measures. Autonomic dysfunction measures could be used in clinical trials. What are our future directions? I think building upon this initial cohort and expanding it to other genotypes and expanding the amount of individuals will be crucial to, and also, as we mentioned, chorea and some of the hypotonia, some of these other things for which scales may not exist, identifying them, capturing them in a quantifiable manner will also be crucial. The watches may be of assistance here and some more complicated analysis to identify patterns of movement that may correlate with dystonia and chorea will be something to look into in the future. But in the meantime, I think identifying clinical scales or maybe even developing clinical scales for things like hypotonia will be something we'll be looking into, with the goal of longitudinal assessment and maybe increasing virtual recruitment to be able to do this. Because lastly, how things evolve over time is what we're interested in, of course. Specifically, when we give treatments, what was it before treatment? What was it after treatment? So can we make it feasible enough to include into standard clinical care so that every individual, whenever they see any movement, any of their pediatricians or pediatric neurologists is able to incorporate this into standard clinical care will be crucial. And finally, we want to validate these assessments together to deliver measurable non-seizure outcomes, which in the future can be used to describe disability in general and not just seizures. And with that, I would like to thank my mentor, Dennis Lal, who's here today, for all the support, the engagement, the knowledge that is imparted. It's very wonderful to work with him and some of the other clinical specialists, including Dr. Thakur, who's the movement disorder specialist at the pediatric neurology department here in Houston. And of course, everyone from the SCN2A Foundation, Leah, Amanda here today, Sean, Christina, and Karen are not here, but really, really appreciate all their efforts through the two conferences that we saw, and then everyone who helped out. So thank you very much.
Thank you, Sunny. There's a lot of questions and engagement in the chat, which I love. That was really, really wonderful. Thank you for sharing back the data that you learned from our kids that participated in this. It's always really nice to see that. If you want to, you could probably stop sharing, I think, at this point, and we can.
Okay.
I think Mary has a question, and Rachel, feel free to take yourselves off mute and ask if you can, or I can ask for you.
I can. Hold on a second. See if we can see me. Can you guys see me? Okay.
There we go. Hi.
Sorry. Driving, so I was on my way back. Yeah, I forget what my question was. I typed it in the chat. Oh, yeah. So I was wondering on the wearable watch, do you have a similar like distribution scale for the SCN2A kids compared to the other kids like you did with the general movement assessments? I'm thinking of it's like the chart you had with the red and the blue that showed SCN2A was a lot more red than the blue. Does it show up the same with the watch or is it different or do we know?
We have not delved into detail in that yet, but what I can say is that, of course, individuals that were wheelchair bound, that are less mobile than others, are clearly being differentiated by the watch in many different ways, including heart rate. So we will be looking into that in the near future. I'm not I won't be commenting on what we may or may not see, but I do think that just based on what we can differentiate already, we hope to identify some differences. And I think also we know from the clinical assessments, subjective assessments, that there's a clear difference between gain of function and loss of function, for example, individuals in terms of mobility. So I'm sure the watch will be able to detect some of those differences. So we'll be looking into that in the near future and then reporting more.
So it's one thing to add.
Yeah.
So thank you, Sunny. It was really great. Just one thing to add. Analyzing the watch is a little bit harder because behavior is also affecting how much one moves, right? Not only and also the drugs and all, this can affect quite strongly how much the movement is in total and in which pace and direction. And also, like, if you're in a wheelchair, you move differently than if you're, with a walker or so. Whereas if you do the exam, Sani can already factor all of this in, right? When he sees the patient and the child. So that's why it takes a little bit longer to get the the wearable data out, because no one has done this ever. Just point in people with SCN2A and related diseases. And at the same time, what we have done is by far the biggest in this space. It's not the only one, but it's also the biggest. And so everything what we conclude from this study will be read and recognized widely. And we want to be careful that we, communicate what is meaningful. At the same time, of course, we try to push forward that, all the energy the families provided at the conferences is really then also used, right? So, but we need to be a little bit more careful because it's probably influencing the field quite a bit.
Hi, Mary.
Hi, how are you? Good seeing
How are you?
everyone. I was curious, my question was if you saw higher baseline heart rate for everyone, like in Colorado versus Anaheim, like the altitude, did that make an impact?
Yeah. So we looked into this a little bit. I think Tobias and I were looking into this because we did actually mark individuals based on where the assessments were taking place, and there was a little bit of a shift, but it wasn't really that
Not
significant. It
significant.
wasn't really that crazy, and we were not like, oh yeah, this is like here and this is there. It definitely wasn't the case. So that initial quality control we definitely did. So, but of course, the problem with the watches sometimes is that the the activities in the pool really determine how much of the electrodermal activity we can use. So that is something to look into how we differentiate. So something we're probably going to do for next evaluations is include a parent protocol. So that would really be helpful because we can't, of course, record everyone at every given time, so to know where they're doing. So we may need to include a parent protocol to say like, hey, from 2 p.m. to 4 p.m. we're in the pool. So we know, okay, this watch activity or this dermal sensor is kind of not really appropriate to be measured because everything will be falsified with the water. So that's something we definitely dealt with, as Dennis said. Like those are the complications you don't think of initially, and then you're like, why is this suddenly so off? And then you realize, oh, it's 4 p.m. What were we doing? Oh, that was the pool party. Okay, sounds good.
And seasons too. If you do studies on, other groups, like I don't know if they were at summer conferences versus winter or fall or, all that makes a difference. Maybe I assume with autonomic symptoms.
So, just, personal opinion. So since it's a blank slate, right? Working in this space, right? With the wearables. We see very interesting patterns from the heart rate and so on, and a lot of things, but it requires so much contextual information. Is there, it typically was at a hotel room, right? So what's going on in that room? We don't have diaries, and you typically, ideally, you want to have a camera in the room. You want to also have there's a lot of things to learn, and probably the biggest learning, which was expected, I guess, is that we understand now how we would set it up actually at home. Again, it's also like a learning experience. It will not be perfect from the beginning, but there will be publications coming out of this. But the main outcome is that we can justify that we need to do this better, more professional at home with a radar and video cameras, which were on every, whatever, 2 days a month or something like this, where the parents for 2 days a month might also do a diary. And then we follow these families like for years and make it like more data-based natural history, which has some informations and apps and all these kind of things, which one can combine. That's probably because there's so much things going on which these sensors detect directly. And yeah, so there will be research studies come out of this, but the end goal of this is at home monitoring.
Yeah. Yeah, I think this is something that Leah and I have discussed and with Dennis as well, that virtual Zoom-based things are really helping in these parameters and then optimizing the standardized scales. So using scales, there are some scales, and this will be the next step that we can just do by observation. I don't even need to be in the room. We'll create protocols that families are able to just record simple things like lying down on the back, sitting, standing. Some of it we did at the conference will be enough to detect dystonia and chorea. And then we can even measure chorea and others through the observation. So I think that'll be the goal. And then, yeah. And as you mentioned, the autonomic symptoms, I think real life setting is something that people often discuss because at the conference, there are all these other individuals, all the other siblings are there. It's so much excitement that may automatically change how the data is perceived. So I think removing the confounder that an external setting provides is very crucial here as well. And this is something we're very kind of aware and akin to.
You guys see, well, first of all, the cross cuffs are always in the pool. So I just want to put that. If you see a cross cuff in there, I'm always in the pool. So I put that in the case file. But I'm picturing like as a potential future that wearables are in the home, and then would it be like parents and caregivers trying to kind of fill in context for you guys as to like what's happening day to day to try to like separate out the noise of like some of the data, or how do you guys like see that being measured?
So
Yes. Yeah.
please go ahead,
Go
Sam.
ahead, Dennis. Okay. So from my standpoint, I think the old school way of protocoling would be, of course, diaries. And I think that is possible. But there are also digital diaries that are available out there where it would be simplified for individuals. I think for parents, it's a lot of difficult work to be able to write down everything, and then you don't know how it is standardized. So standardization of diaries is something that the epilepsy world does a good job in. And there are new diaries out there digitally that I've looked into where there's standardized wordings for what the individual is doing. So there can be time for sleep, pool, things like that. So they can just click uh, easily for themselves. And that timer kind of starts. And then whenever they switch to something else, they can click another button on an app. And that can automatically be translated into data that we can utilize. So I think that would be the best way moving forward. Make it easier for everyone else to be included in research. Because I think one of the issues with research involvement is that it takes a lot of time for families, and they have their kids, they have jobs, they have other activities in their life. So make it easier for everybody. Make it easy even for example, caregivers that the families have involved a lot of times. To be able to do that will be the best way forward for me, my standpoint. And then Dennis, you can add
Yeah,
on.
so I would give it one step further. So I think one can, for example, combine a wearable with a motion detection camera. So in that way, for example, overnight in the bedroom, right? So every time the child moves, it suddenly the video is recorded, and then at the morning you can stream it to a radar, right? From at a university, for example, and they provide the annotations. So hey, child moved. It was not a seizure. It was more like just turned around. You can even have underneath the cover, right? You can have like motion detection, even and then there's you can have pulse ox and all kinds of things. So I think you can bring in a lot of more technology, which you only put on like let's say 2 days a month or so, and that doesn't. And then you can stream a lot of information where then a human, like the camera, for example, can just review like okay, 15 instances from that night, what was going on, and then they annotate what's happening during that time. And that way you can even reduce the burden for the families even more. That's one thought. And with the video recordings, at some point AI will be good enough to say, hey, that looks like a seizure. That the child got up. You can even do like the angles, right, the fingers, and so to the head, what the movement is. And you can
Sure.
even then see if posture changes over time, if you do it longitudinally, right? So and then parents can release the medical records. You can get all the drug information out at that point in time. And so so there's a lot of ways I think where one can reduce the energy to get like really rich data. Yeah, yeah.
It's great stuff. Keep up the good work, gentlemen. That's fantastic. I'm always fired up when I get on these calls. That's what I'm talking about, guys. Keep it up.
Yeah.
I have a
Awesome. Thank you.
question.
Yeah.
Curious about the seizure watches. So what they measure with those is very, I mean, I assume similar, like the tonic movement. Do they measure heart rate or is it skin? I briefly was looking up. Are you able to work with them, maybe gather some data from what they've done with like motor, more specifically motor?
With
Yeah.
our watch is the seizure watch,
Yeah.
but we don't have the algorithms running them. So
Yeah.
that costs a little bit more money. We could ask, for example, but they're not benchmarks, and they're only benchmark for motor seizures, like really strong
Yeah.
movements. But in general, the Empatica Embrace Plus watch, which we are using, is the one which is FDA approved for convulsive seizures.
So it's the same. It's measuring the same thing.
Yeah,
And
yeah,
that's
it's just an algorithm they run over the sensor data which we have.
do they
Yeah.
have the velocimeter, whatever it's called, accelerate, whatever it's
Yep.
called?
Yes.
Do that?
Yeah.
Yeah.
Yeah. That's
It's
the
the
same
exact
thing.
same, the very
Yeah.
Yeah.
exact same.
Yeah, it's
Yeah.
the exact same thing. What they do is, so it's important. So how these algorithms work is you have patterns, and the algorithm detects patterns. So there's movements when you just like move your hand, and how does that differentiate from when a seizure is happening? Is the amplitude difference and the way the acceleration changes different to the ones where you're just moving, waving hands? So they have a lot more data, of course, across so many different individuals. So they've been able to identify thresholds that detect seizure. But this is still, so how these watches work for us in the clinical setting is that they will flag activity that looks like a seizure. And then oftentimes you will kind of check back with the individuals and see like whether that correlates or not. But they basically set mostly lower thresholds, so you're able to detect more of these activities so you don't miss a seizure. And then you can kind of watch back and say like, okay, this looks definitely like a seizure. And that's how they refine the algorithm further and say like, okay, this was a seizure, this was not a seizure, and they move forward based on that. So it's essentially the same data,
So did they
just
use videos during their studies? Did they record?
yes.
Like, could you
So
go to them and ask them if they like you could analyze that data to do their motor part?
yeah, I mean, we could, but they already have these algorithms that is using the data, so we could essentially just get the algorithm if you pay more, I think.
Yeah,
Yeah.
so they could run the algorithm, but it could cost money, and that's
Yeah.
the issue. And the algorithm would probably lead to a lot of false positives, which we cannot check.
Yeah.
But if we would do this, for example, this at home monitoring study, we would also have the video, and we would then have an also like a rater saying, hey, that actually looks like a seizure. Probably we would have a phase zero where we have even some of these beacons or some other EEG bands. We could benchmark first also in a hospital setting how good it works in children with SCN2A in the EMU, for example. Um, so, mm, so yeah, there's in theory, yes, but we don't have the license or the upgrade for running this. And we did it at the conference, most of this. So, but in a future setting, and if we want to do this better, which we need to, we would definitely also run these algorithms, but we need to do also some benchmarking in parallel.
Great. And then we had a question by Miriam and Rachel about differences between the genetic variants, like gain of function, loss of function. Yes, we do see differences. So the scale-based data, I've shown it previously. I can try and pull it up even. But essentially, we see that the gain of function patients with early onset seizures and DEs do seem to appear to be more severe on the movement scales, and that there are certain loss of function variants, specifically the PTVs, that are significantly milder on the scales and may have very discrete kind of dystonia, discrete gait dysfunction that may not be captured. Uh, Now, and then the second question was from the watch data, we're still looking into it, but from the clinical scales, definitely there's a difference. I will try and pull up the data while we're talking. And then how does LOF compare to controls? I think on the movement scales, a lot of the times you may not be able to differentiate controls from LOFs, so they may look extremely similar. However, the cognitive component is not captured, which is why it's so essential to capture more than just movement, because there's, of course, a very significant cognitive phenotype, behavioral phenotype. So making an assessment more inclusive for other outcomes will really be the differentiating factors. And then we have multiple different parameters with which we can compare. So on the movement scales, they may look very similar. This is a very important question. So how I envision a future trial, for example, would be inclusion of both motor phenotypes, seizure, and clinical data, and then these behavioral outcome measures, which are from questionnaires, as well as like inpatient assessments like the ADOS, which does the autism eval. And then when you put all of that data together, then you can really differentiate loss of function from gain of function from different genes. And then you'd identify the PCA that we showed, the dot plot map where the dots are different. Then you'll be really able to differentiate them from one another. So we're really kind of not in the even advanced stage where we can say like, or in the early advanced stage where we can like really put 5 different parameters and scales together. And we haven't even done that here. We haven't even put the watch data and the movement data together. And as soon as we did that a little bit, we saw it recently, we could really see a little more clarity even in the signal. So I think just adding more data, unfortunately, sometimes is the answer. And in this case, that may be true as well. And I can try and show you the difference. Let me pull that out. Of course. Give me 1 second.
No pressure, Sonny.
Oh, there's no way. It's just too much data. I just don't know where to look anymore. Most of the time, I'm kind of confused. Where's this? Oh, there we go. Okay. It is very busy on this plot, and it is not very optimized for individuals who haven't lost their mind yet. So please, apologies. All right, can you see this screen? Okay. All right, this is kind of a little crazy, but so this plot, you can see the plot, right?
Yes.
Okay, so these are controls. So this is basically plotting the raw scores of individuals with different genetic variants, and I focus on the sodium channelopathies here. And what you can see, for example, is that the controls look very homogeneous. They don't really have any large dots. So the larger the dot, the worse the raw score. Compare that to the specific missense variant here. These missense variants were all the gain of function variants, and you can see that these dots are suddenly super, super large, and certain things aren't even being scored. And that was the severe group, and this was mostly the gain of function group. Compare that, for example, to the PTV group, who all essentially look like controls other than in speech. And there we know is that this is something I didn't talk about because it gets too complicated, but the speech components are essentially the components that have a cognitive component, of course, because speech has not only just vocalization, but a lot of it is cognitive impairment, intellectual disability that inhibits their speaking. So this is where I can, even on the scales, and I kind of lied earlier, even on the scales that are doing here, we can really differentiate controls from PTVs based on just this aspect. And that really told us like, okay, we really need to measure the cognitive behavioral outcomes because without them, we really are missing a significant chunk. And adding that may also help us define differences between certain groups. So yeah, this is kind of a preliminary look into this phenotype variant-driven analysis that we're doing, but we're not focusing on it too much just because it will be hard to justify differences in a small cohort size as we have right now. But we do see some meaningful kind of preliminary answers that look very similar to what is reported in the literature, which is very good.
Amazing, Sunny. It's past the top
Yes.
of the hour, and
Yeah.
Sunny, thank you so much for everything that you
Yes.
do for
Of
our
course.
community. You are doing some incredible work, and you are an amazing guy too. So we are very grateful for you spending the hour and nearly an hour and 15 minutes with us.
No,
Um,
thank you so much. Absolutely.
thank
Anytime.
you. And everyone, thanks for joining us today. Always on the 20th. Um, come and join us. Have a great
Thank you.
afternoon, everyone.
Have
Thank you
a
all. Have a good
good
day.
bye.
Thanks,
Thank you. Have a
Sunny.
good day. Bye bye. Bye.